Hi, this is Dr. Purcell. We're going to talk a little bit about pain, and this time the content for our concept of pain is going to be analgesic drugs. I want to point out to you that in your Pharmacology Made Easy module on pain from ATI, they cover this topic extremely well. There's a very good patho behind it, and then they cover all of our drugs with very, very good information. So I am not going to recount all of that information here. Rather, I'm going to do this to highlight certain points that are important for you to remember and maybe bring in some other information. So I want to start with a video here that will help you understand what things are when they're called Class 2, Schedule 2, Schedule 1. I don't know that we've actually touched much on this before, and it's going to be important for you to understand why certain drugs are called a Schedule 2, 3, 4, etc. So let me get this started here.
Based in most ways, but it's not as commonly used, and it's not something that we often encourage its use. Methylphenidate, short-acting barbiturates, and strong opioids are also used. A good example of a strong opioid that's used in clinical practice is fentanyl, which has now become one of the most abused opioids in the market today. The Schedule 3 drugs have a lot of medical use. There is a moderate abuse potential with them. So these are the anabolic steroids that I had mentioned earlier, barbiturates, and sometimes Class 4 drugs are not used. Mostly
All right, let's get back here then to our slides. Oh, there we go. Don't want him to play again. He's still playing anyway. I need to get him to pause. There we go. So let's talk about opioids and what some of the terms, key terms that you need to know when it comes to pain management and the use of opioids. Tolerance is going to be a key word that you need to understand. And tolerance is something that's expected and is quite common in the use of opioids, and it's a physiologic result of chronic opioid treatment. So this isn't really what's going to happen with somebody who's post-op and having a PCA pump and maybe 2 or 3 days of opiates. This is something that's going to happen as somebody has chronic pain and is long-term use of opioids. So the result here is that a larger dose is required to maintain the same level of analgesia. Again, it doesn't mean somebody is addicted because they now need higher doses. It means they have a normal physiologic response to opioids. There we go. The next key word that you need, key phrase that you need to understand is the term physical dependence. And again, it's a normal, it's expected physiologic adaptation of the body in the presence of an opioid. So these things also happen. And this means somebody who's been on opioid therapy for a long time, and I would say anything beyond a month. It depends actually on the drug and the situation, but it's prolonged use. It means that if we withdraw the opioid, they will have a withdrawal, and it's very unpleasant, and it's not something that we really want to see happen. But it happens because of the physiologic adaptation of the body to the drug. And it doesn't mean someone's addicted just because they have physical dependence. It is not a psychological dependence. It is physical, and it's normal and expected. So what this means is if we're going to take somebody off of opioids, we must taper them down and take them off very carefully. So then let's talk about psychological dependence. Psychological dependence is a pattern of compulsive drug use. It's characterized by continued craving for an opioid, outside of the scope for pain management. And it's also characterized by the need to use the opioid for effects other than pain relief. I want to play something for you here to let you see what the physiologic dependence can look like and how bad it really is.
Fentanyl addiction. This is the new young face of fentanyl addiction. Before and after. 22-year-old Katie Davis, forehead and chin clawed open by her own fingernails because the use of fentanyl makes her skin crawl. I spot her on the strip, Surrey's infamous drug hangout, and ask if she'll talk to me. She puts cover up on her raw skin.
I literally just did my last round.
Katie settles in to tell her story. How she ended up living on the street 3 months ago, addicted to fentanyl.
Well, I've been using, it's actually funny, well, it's terrible. I don't know if it's personality. I've always been like addicted to something when I'm shopping or Facebook or whatever. And I did an oxy. I got addicted right away. And then I got a thyroid. I went to dealers all the time. I remember the day that somebody calls and my dealer said, you know, I got these new pills that are big. He didn't tell me they were fentanyl because nobody knew what fentanyl was. He just said they're 100 times stronger than I know. And I was just like, okay. Because I, you know, they're not toxins. He's making these different forms and two
I hope you heard her. I hope you heard her talk about how she was hooked immediately. It's such a startling reality that that is how that happens. I'm trying to get my screen to go back here to show you. And did you hear her talk about how her tolerance? I'm going to do a stop share here real quick because it seems to have hung up. There we go. Her tolerance has gone up. So she knows as a user exactly what that means and how it means that she needs more drug. When she started, she said she would use 2 lines out of the 4 and it would last an entire day. I'm sure that that's now much higher. Then we're going to talk about the analgesics and toxicity and management of them. And one of the drugs we use for that is called naloxone. It's also known as Narcan. And when a patient experiences severe respiratory depression, that because of opioid overdose, we have to give naloxone. And sometimes we have to give more than 1 dose, depending on how much drug they took and how much it takes us to get them breathing again. Now, what you will see when they withdraw from an opioid, so we talked about dependence, physical dependence. So you will see when we give the naloxone, the what would be a withdrawal because of the dependence, and it's immediate and it's very fast. And you see anxiety, irritability, chills, hot flashes, joint pain. I mean, everything along here. I'm going to show you another video here that takes us on a journey with EMTs that have to administer naloxone in the public, out in the city. And I want to look for some of these withdrawal symptoms that you see as the naloxone starts to take effect on people. Also, I want you to note when there's a response to a person who's in a bathroom and they're on the floor and the paramedic is responding to administer naloxone. You'll be able to see it quickly on the floor. There's also a lancet that you use when we're checking blood glucose. And I want you to see that because that's another thing they had to check. They had to determine, is this hypoglycemia or is it opioid overdose? And they have to make those assessments very, very quickly. But really only a nurse or somebody who understands that would actually notice those things are there. So let me get that started for you.
This is the most stressful part of the job.
Brian Trains has no idea how many of the 914 deaths next year in his shift. It's just
say 30 minutes, 45 minutes, as far as whenever it's showing up. Like this man who was long gone before anyone found him in a public washroom. Swayze thinks that's likely remembering the second because cold weather forced users indoors to use in places with no AC. Took off before he got there on a block where anyone in a uniform is not. You're on the other side of it, really agitated. You should either stop and keep going. It's a very
So it's tough to see, but I think it's important for you to understand just how powerful the addiction to opioids can become and what it does to an individual's life. And I want you to also see that that is not the same thing as somebody having dependence and tolerance. I'm sorry, I'm having trouble changing my screen for you. There we go. I thought we could. I'm really having some issues today. We will do this. And then we'll do that. All right. Thank you for bearing with me. There we go. So the having the Narcan and the naloxone out on the streets, on the front lines, has really saved many, many, many lives. You will likely give it in the hospital if you work in an area where you give a lot of opiates, or if you work in an emergency room, possibly. So that's an opioid antagonist, and it competes on the receptors like mu for with an opiate. But now let's talk about actual opiate agonists, and these are being used for analgesia, not for anesthesia or anything like that, but for pain relief, for relief of discomfort and pain. So here's some things that are going to interact with our opioids. Now remember, think about the illicit use of opioids out on the streets and what it induces in people. And when you realize this is very much central nervous system changes, the drugs on this list should make sense to you. The top one, alcohol, if you mix it, alcohol is already a CNS depressant, and when you mix it with an opioid, you get a synergistic effect, and the person can actually die from that. And antihistamines also, like diphenhydramine, because of the effect it has on the central nervous system, and if you combine it with an opioid, can cause CNS depression significantly enough to cause death. As we go down the list, the same thing, all of these have CNS effects, barbiturates, benzodiazepines, the monoamine oxidase inhibitors, and there's others as well. So when you're going to give opioids, you really want to check somebody's medication list for anything that would cue you as a CNS depressant. Let's talk about our first drug, codeine sulfate. And so this is listed here as for pain for the course, but it's actually also listed as an antitussive. Codeine is a Schedule II drug, but it's less effective than morphine. And the problem with codeine is that it has a ceiling effect. So that once it reaches a certain dose, we can keep giving higher doses because remember that the tolerance happens and the person needs higher doses in order to get pain relief. Well, there's a certain ceiling that we hit with codeine that no matter how much higher we go in dose, it doesn't relieve pain. It only causes more side effects and adverse effects. So that's why, like with chronic pain, it's not a good choice. But it's an excellent choice for an antitussive. Now, remember in the video when the paramedic was talking about the lack of oxygen in the opioid overdoses, and that's because respiratory drive and the suppression of the respiratory drive and the changes in gas exchange are what caused that from the opioid overdose. And so codeine also causes that a little bit, but not to the same extent that our morphine does. And that is what makes it a beautiful antitussive or anti-coughing medication. And it's generally combined with something else where it's a liquid when it's prescribed as an antitussive. And it does cause stomach upset, and you'll have people tell you they're allergic to it because they got really sick when they took it in their stomach, but that's more of a adverse effect than an allergy. Then we have fentanyl, and this is our first video that we watched with the young girl. Sadly, she's very young, addicted to the fentanyl. And it's a synthetic opioid, and it's used to treat moderate to severe pain. It's Schedule II. It comes in various forms. It comes as a patch, which is really good for chronic pain and chronic pain syndromes and use in that area because it gives really enduring, long-lasting analgesia, and people don't have to carry the pills with them. It can be a lozenge. It looks like a lollipop kind of that you put in the buccal area of the mouth. We use that with little children sometimes to help get their pain under control. And lozenges that you can suck like a cough drop would look. Something to understand is exactly how strong fentanyl is. It's actually, ordered in micrograms, and because it is it's 100 times more potent than morphine. That's why that young girl said she could, for a little bit more money, she could take the fentanyl and have it last all day, and so it actually would cost her less money in the end because she wasn't having to buy as much drug to meet her needs. Hydromorphone is known as Dilaudid, and you'll see this quite often used in our patient-controlled analgesia or PCA IV pumps, and also morphine is used there. Some people don't do well with morphine. It causes them to be nauseous or itchy, and so we'll use Dilaudid as an option, and it's extremely good for severe pain. But it is also extremely potent. 1 milligram of IV or IM hydromorphone is equivalent to 7 milligrams of morphine. So the fentanyl was a 10 milligrams. We had a 0.1 milligram here of fentanyl was equal to 10 milligrams of IV morphine. And then now we're looking at 1 milligram and is equal to 7. So it's still more potent than morphine, but not quite as potent as fentanyl is. And then we have our good old morphine sulfate. And one of the things about morphine, fentanyl, and hydromorphone is they do not have that ceiling limit. So somebody who needs to have chronic pain management with opioids and develops tolerance, and we go up on the dose. So instead of 25 micrograms, now we're going to do 50 micrograms and then 75. What's nice is there's no ceiling. We can keep going up as long as the individual is tolerant and able to not have adverse effects they've built up enough physical tolerance that we can continue to go higher and higher on those doses. We would never start somebody who's never had an opioid at a high level. It would probably kill them. We start at the lowest dose and then work our way up as tolerance develops. Morphine is a naturally occurring opioid derived from the opium poppy. And it is the drug prototype for all opioid drugs. It is also a Schedule II, and its indication is severe pain. It has a very high abuse potential, but much higher now is, of course, the fentanyl and the hydromorphone. One of the very nice things, morphine comes in a variety of forms. It can be taken orally, and it's an immediate release, we call it, so that its onset is pretty quick. But it doesn't last as long, or it can be a sustained release, typically called MS Contin, morphine sulfate continuous, and where it can last as much as 12 hours with one dose. And it even has a rectal dosage form and a suppository. It's IV, and that's the things that make it just a wonderful drug for controlling severe pain. Something I want you to think about is if you're having to give somebody IV push morphine, and you will, there's not too many settings where you'll work where you won't have somebody who may require pain medication, is that you don't take the syringe and hook it into the IV and just push it in like you do an injection, which you would give like IM or sub-Q. You know, this actually, depending on the drug, you have to know the rate of administration. And the thing about morphine is you will see, unfortunately, your nurse colleagues with very little regard for just how dangerous this drug can be when it's pushed IV way too fast. And I have a link here, and we'll see if my screen's going to want to share or not, but it's to the Davis Drug Guide. And let's see if I can pull this up for you. And what we have here is morphine, and I do hope you're seeing this. I'm going to come down through the drug guide. On the left here, you can see the table of contents for what you can see in here. And like there's your pharmacokinetics and half-life, and like they put it in like adults, it's 2 to 4 hours. The absorption is widely distributed. It does cross the placenta, so you don't want to give this to women who are pregnant. Here's your protein binding information that we talk about so often. Now down here, I want to talk about IV administration. IV push, and that's what you would do. You would have to give somebody maybe 1 to 2 milligrams of morphine IV push. First thing you have to do is the manufacturer does recommend that it be diluted. So you'll draw the drug up from a vial, and then you'll need to dilute it further with at least 5 mLs of sterile water or sodium chloride for injection to achieve this type of a concentration right here. Now in red, under the word rate, in red and bold right there, it says administer 2.5 to 15 milligrams. So I said, let's say we're going to give 2 milligrams or maybe 4 milligrams. These are typical doses that you'll see. So let's just say it's 4 milligrams. And after you dilute that, it may have been 1 ml of volume that you drew up equals the 4 milligrams, but now you need to dilute it further. And so you draw 5 mLs of normal saline for injection. So now in your syringe, you have a total of 6 milliliters, 6 mLs. You have to administer that over a minimum of 5 minutes. So next semester, when you're in your level 3 courses, you will learn how to give IV push medications and how to time that. That's one of the reasons it's essential that you as an RN wear a watch so that you can know how fast you're pushing your drugs. But I want you to see what happens. Rapid administration can lead to an increased respiratory depression, hypotension, and this is a big one, circulatory collapse. And it's fast. So I would say you want to make sure that you are always very respectful of your morphine sulfate when you're giving it IV, and try to advocate for your patients and other clients when you see your colleagues pushing this drug too fast. And we talked about naloxone already, but just it's here in this order of that we're going through. And it is a pure opioid antagonist. So it is strong. It'll knock all of the opioid off of those receptors, the mu receptors, and it takes its place. And so that does cause a complete or even partial reversal of an opioid-induced respiratory depression. You have, we talk about ketorolac in inflammation in that concept, but it's, pain is often a result of inflammation, or they go together. So it shows itself here again with us when we're talking about the concept of pain. And it is a category of NSAID called acetic acid derivative. It has very good anti-inflammatory properties and very powerful analgesic effects. It's really good for use in moderate to severe pain and works very well in our post-operative setting. But some of the adverse effects you can see here that can occur are renal impairment, really having not just GI pain, but the source of the pain is usually because there's damage to the GI mucosa. It is limited in its use to 5 days max. So when you think about a post-operative setting and its use is so fundamental there, we do have people who are recovering and their wounds, their surgical wounds should be healing. And as wounds heal, the pain diminishes. And that's, so by 5 days, they should no longer need this acetic acid derivative, and they should be able to move on to another form of pain control. There's our good old ibuprofen that we've also seen with inflammation, that concept, and we've seen it with the concept of intracranial regulation with fever. And this is a category of non-steroidal anti-inflammatory drug NSAID that's called a propionic acid derivative. And it's often used very, very successfully with musculoskeletal pain, like with osteoarthritis, with dental pain, for instance, rheumatoid arthritis. So when somebody has even like sprains or any kind of musculoskeletal pain, this is a really good drug of choice here. And those types of pains generally are accompanied by inflammation. And so that's one of the reasons it works so well. You want to be careful because it can cause GI ulceration and bleeding, which our older adult is highly prone to, or anybody that has peptic ulcer disease or alcoholics with chronic gastritis may have maybe higher risk for developing GI ulceration and bleeding. So we want to watch them closely for signs of that. And then we have our good acetaminophen, also known as Tylenol, also known as ACAP, and it has analgesic and antipyretic effects. Again, we've talked about acetaminophen when we talk about temperature control, like for fever. But it has little to no anti-inflammatory effects. So the kind of pain that is associated with inflammation is not going to have a lot of relief here from acetaminophen. The better choices are ibuprofen. But it is a very good pain reliever for things such as headache. And so it's very effective there. And it is available over the counter, and you have to be careful because it's typically in combination with many other products. We do use it also in combination with our opioids, even like codeine. You may have heard reference to things called Tylenol number 3 or Vicodin, and those are combinations of codeine or hydrocodone along with the acetaminophen, because the two together work very well to help moderate and mild and moderate pain as well as fever. Something to keep in mind with acetaminophen is that it has the potential to be very damaging to the liver. So we do have a maximum daily dose that is used to be 4,000 milligrams, and now it's 3,000 milligrams per day. And then for somebody that has any type of liver disease, we typically don't want them to take acetaminophen at all. But if we really have no other choice, and that's the only drug to use with them, we'll limit that to 2,000 milligrams for them. And we try to limit the dosage to 2,000 milligrams for our older adults too. So if you know somebody, a client, doing home visits or talking with an older adult who uses acetaminophen, encourage them not to take the extra strength Tylenol, because that one is 500 milligrams per tablet, and the regular strength is 325 milligrams. So if they're taking 2 regular strength acetaminophen, they will probably get sufficient pain relief without coming so close to the dose that's the limit for them. And the thing is, Tylenol has, or acetaminophen has, it has a half-life, and so it is going to wear off, and they are going to need another dose. So knowing that, it's better that they're taking the lower dose throughout the day than the 500 milligrams, where they take 2 of those, it's 1,000 milligrams. And in 4 or 5 hours, they need another dose. They might be at their max in less than half the day. If somebody has, I say if someone has liver dysfunction, they can take up to 2,000 milligrams. And of course, if that's the limit if you don't have any other choices. But that's usually where we try not to use acetaminophen if possible. There's a cute little video here about the dangers of acetaminophen in the pediatric population and some things that can happen. I'm not going to play it here, but I would encourage you. I think it's nursing students actually who filmed it, and it's pretty quick, but it's a very informative, and it involves a child, and so I think it's interesting for you to watch. And I know you'll carry the information forward into pediatrics in a couple of semesters. Then we have transdermal lidocaine. Transdermal, the term transdermal means it's a patch that you will put on the skin. And we have different types of patches for pain. And depending on what the active ingredient is going to determine how the patch is used. In this case, it's lidocaine. And lidocaine is a topical anesthetic. So the patch needs to be placed on the region of the source of pain. If it's a patch that has a different type of drug in it that it gets absorbed systemically, that patch can go anywhere. It doesn't matter where the pain is. But in this case, we're talking about a topical anesthetic, lidocaine, and it works quickly and it works very well. But we also use lidocaine with cardiac issues. So we want to make sure that the individual who's using these transdermal patches doesn't, number one, put too many patches on, and number two, doesn't wear them any longer than 12 hours at a time, because then we start getting into a systemic absorption that can actually lead to some cardiac dysrhythmias. So we put this transdermal lidocaine patch directly on the area of discomfort. And this is typically prescribed for post-herpetic pain, meaning after shingles, that herpetic neuralgia, the neurologic pain that remains after a shingles outbreak. And I say post-herpetic because the skin needs to be intact. We don't want to have the open lesions and place the patch on top of the open lesions. So they can put up to 3 patches in the area, which is good because it's usually the pain follows along a nerve tract, and it's not just like the size of a quarter or a 50-cent piece. It's usually the size, several inches long. So you can put up to 3 patches over the area that's painful, and then leave them on for 12 hours. And then they need to take them off for 12 hours. And then 12 hours later, they can put them back on again. And that way we don't get the systemic adverse effects that can cause cardiac issues. I have a link here to our book, the Lilly textbook. And here's our lidocaine transdermal. There it is. Oh, it makes you hydromorphone. Where's my lidocaine fentanyl? We'll find it. I wanted to just show you here. Okay, lidocaine transdermal. Okay, well, the link. It must be right in here because it's, there we go. No, that's codeine. Apologize. This is not what it's supposed to do. When I click on that, it's supposed to take me right here to my lidocaine, but it did not. But I was going to show you here in the book where you can find the information about lidocaine. There's our naloxone. So you have a copy of the link here in the slides. So here we go. There's my lidocaine transdermal, and that is on page 158 in the most current Lilly that we're using right now. And again, it says you can use up to 3 patches on a large painful area, and they're not worn longer than 12 hours a day. And they're only applied to intact skin with no blisters. So remember, if you think about that I'm not going to put this patch on blisters, it'll help you remember that the indication for the transdermal patch is post-herpetic neuralgia, because it's after the herpetic lesions have healed. Then we have gabapentin, and this should also take us right back here to our Lilly. There we go. And gabapentin is mentioned in the same chapter as under the heading here of adjuvant drugs commonly used in the treatment of neuropathic pain. And so gabapentin is an anticonvulsant, and it works. We aren't 100% sure of its mechanism of action. It's one of the things that you hear about it when we talk about our anti-epileptic drugs or anticonvulsants, and it's in that chapter. But it's not, we have such better drugs now that we don't use it quite as often anymore, especially not by itself for treatment of seizures. It might be used with another drug for treatment of seizures, but the most common use for gabapentin is for neuropathic pain. And so think about your individuals who might have peripheral neuropathy, things of that nature, or even post-herpetic pain, neuropathic pain. And so this is where our gabapentin comes in, and it shows it right here, gabapentin. I'm going to highlight it, but I think you see it. There we go. And it might be, and we'll combine that with other maybe opioid agents to help with pain control. So don't be surprised if you have somebody who's receiving gabapentin, and you look it up and you see that it is a anticonvulsant, but they don't have epilepsy and they don't have seizures. You'll start looking to see if they have any neuropathy. Then we have our aspirin. It's a great drug. People have been using it for 100 years or more for aches and pains, and it is an NSAID also in the salicylates class. It's acetylsalicylic acid is the long name of it. That's why it's abbreviated ASA. And it's in many, many combination products. In Excedrin, the medication for headaches, it's an excellent headache medication. It's a combination, and it has caffeine, it has acetaminophen and aspirin. And the 3 work together to help very, very well with headaches and even migraine headaches. This is probably the most widely used drug in the world. And it's not only used as a pain for mild to moderate pain, but it's used for antipyretic in that form for bringing down fever. It's cardioprotective after a myocardial infarction. And we do want to remember that in our children and teens with flu-like symptoms or other viral symptoms, we do not want to use aspirin because of the risk for Wave syndrome. And then somebody who's on warfarin therapy, which is an anticoagulant, we would not want to combine aspirin with the warfarin therapy because it could lead to prolonged bleeding, and it could even cause a GI bleed. All right, so nursing implications, and this again is covered very, very well in the ATI module. So I'm only going to pull out a few important topics here. And one of the first ones is that you really need to assess pain before and after you medicate somebody. And that is primarily so that you know how they responded and if they've responded and if it's adequate or not. There's no other way for you to know if the medication you're giving helps to achieve the goal for the person. And the only way you can do that is to ask them. And we have to document that response, and that you really are obligated to document that and to go back and reassess. Anybody taking medications for pain needs to be strongly and frequently educated about not taking over-the-counter products without checking with a practitioner. because we need to know what the active ingredients are. And they could easily pick up something that has more acetaminophen in it and another one that has acetaminophen, and then they're having an acetaminophen toxicity. I do challenge you when I do this lecture, I challenge you to go to Amazon or even Walmart or Walgreens or CVS and enter the search box cold and flu remedies. And I want you to go through all of the things they present and see how long it takes for you to find a product that has just one active ingredient. And the challenge here is so for you to see that, holy cow, you think you're just picking up a basic cough and cold medication, but it's got a ton of products in it. And if somebody's also taking acetaminophen because they have a fever, and then they take this combination product, which also has acetaminophen in it, it could cause some unwanted adverse effects. So, when you have a little time, I challenge you to do that. So when we have our opioid analgesics and you're going to administer these drugs or teach somebody about taking them at home, you want to make sure that they understand that if it does cause GI upset, it can be taken with food. That's fine. If you're in the hospital, and especially if you're giving this IV, we want to make sure that all our safety measures are in place because of the central nervous system depression that can occur and the effects that happen. And people can fall out of bed. They can get up being confused, or they get up and they have hypotension, or they're dizzy and they have a fall. So you must ensure all the safety measures. And you must be very vigilant about watching vital signs, especially respiratory rate and pulse oximetry, so that you know their oxygen saturation. And that if every hospital will have a protocol about what the level, the threshold is for respiratory rate or for gas exchange, pulse oximetry. And you'll have to, if they reach that threshold, if they go below it, you have to contact a provider and you have to give naloxone. Probably the biggest problem with opioids for people who have chronic pain is going to be the constipation. There are, you take an opioid and it can cause sedation, itching maybe, little nausea. Those things tend to abate as the body becomes adjusted to the opioid, or if we had to increase the dose, those side effects come back, and then the individual adapts, and those side effects tend to go away. However, the one that does not go away is constipation, and it's because of the effect on the GI tract, and it actually affects peristalsis and slows it down. And this can become quite dire and quite bad. And so we really need to make sure that anyone who's on a chronic opioid is also taking measures to keep their valves moving. So we need adequate fluid intake and fiber. This is discussed in Lilly as well in your book. They go into this under the nursing area for implementation. You will always monitor for adverse effects. Respiratory depression, it can be manifested in different ways. Generally, the first thing you're going to see before the breaths per minute even drop is a change in mental status. It's going to be increased somnolence. It's going to be sleepiness. Somebody falling asleep while they're talking to you, or difficulty to arouse. That's actually your cardinal sign that somebody is having changes, enough significant changes in gas exchange that it's causing their brain to be deprived of oxygen. And so it's at that point you need to do a full assessment and probably give some naloxone. And of course, as the nurse, you need to monitor for those therapeutic effects. If you give an opioid or any analgesia for pain, the individual should have a decrease in how they rate or describe their pain. That's the goal. If they don't, then that's a conversation to start having with the provider and maybe change the drug or increase the dose or see what's going on. Hopefully that will also result in increased periods of comfort, increased quality of life, and in some cases decreased fever, for instance, with acetaminophen. And that's the end that we have there. And I'm sorry, I think the screen just went blank for you. But I will post these slides along with the recording so that you can follow along. I want you to know that there are 52 slides here, and I started with the first two, and I clicked on the star, and it took me to this slide where I started this recording, if you need to do that as well. Thanks for listening. Take care and happy studying.